Good evening to all my co-presenters. Thank you so much for inviting me, Dr. Smita, as always, and of course the Ksos team. So let's start with the different types of ocular trauma which happens include contusion injuries, penetrating injuries, chemical and thermal burns, and rarely radiation damage also we do see. Now, when we talk about the prevalence of ocular trauma, it is like these are some of the South Indian studies which have happened, which ranges from almost 4% to 7.5% in various studies. Now, hyphema amounts to almost 81% of the presentation, and other presentation include angle recession, iridodialysis, cyclodialysis, iridoschisis, and various posterior segment injuries as well. As we all know, blunt ocular trauma causes a anterior-posterior compression, and there is a posterior displacement. That is why usually you get these rings of trauma injury along this circle. So, when we talk about glaucoma, it can be either early onset or late onset. Early onset is trabeculitis and hyphema, and late onset include other forms of glaucoma like angle recession, ghost cell glaucoma, and lens-associated glaucoma. As you all know, hyphema is one of the commonest presentation. What happens in hyphema? It's basically due to the distortion of the anterior chamber angle, there is rupture of the iris or ciliary body vessels. So usually 1/3 of all the hyphema patients, there is an evidence of increased intraocular pressure. So the reason for the glaucoma is because of the occlusion of the trabecular meshwork by either blood clot, inflammatory cells, or even the erythrocytic debris. So rarely the pupillary block also can happen because of the 8-ball clot which is there. Hyphema, as you all know, there is different gradings of hyphema which ranges from grade 1 to the grade 4 as shown in the picture, the last picture, which is as an 8-ball hyphema. Then you have this microscopic entity also, which is just the circulating RBCs. A thorough evaluation is a must when we do a hyphema case, when we see an hyphema case. Gonioscopy and indirect ophthalmoscopy, there is no hard and fast rule about 1 month. It can be even as early as 2 weeks also, we can do a gonioscopy. Definitely ancillary investigations are mandatory, especially a B scan, some of the bleeding tests and kidney and liver function tests, as we are going to give some drugs which can affect them. And if you suspect any kind of a penetrating object, CT scan orbit has to be done. Always think of some differential diagnosis, whether the patient had pre-existing rubeosis or any kind of malignant neoplasma or juvenile xanthogranuloma, because we have seen these conditions, even a trivial trauma can result in hyphema. So it's important to understand whether the patient had any of these underlying conditions when he or she had the trauma. The commonest complications being corneal blood staining and glaucoma, and other findings being posterior synechia and PAS, and rarely glaucomatous optic atrophy also can happen. Now, the corneal staining usually it depends on the initial state of the endothelium and how much of the trauma has happened to the endothelium and the amount of total hyphema. If it's an 8-ball hyphema, chances of corneal staining is more, and whether there is an increased IOP for a prolonged period. Other associated findings, starting from the lids to the posterior segment, you can have various findings, including vitreous hemorrhage, retinal detachment, and commotio retinae is a very common finding which we see in posterior segment. These are the various presentations which we have seen in our clinic actually, different type of trauma, and which includes penetrating as well as blunt. What are the two main goals when we treat hyphema? One is IOP control, and we have to prevent the chances of rebleeding. Of course, we have to instruct the patient to have bed rest with head end elevation and use of eye shield. Medical management includes all type of anti-glaucoma medications, avoid prostaglandin analogs as well as a pilocarpine. Pump in lot of steroids. It can be either topical as well as the oral steroids. I'm a great fan of using oral steroids if there are no contraindications for the patient. It does help in resolving the hyphema and therefore the IOP as well. atropine. When do we do a surgical intervention? This is the typical textbook explanation of a surgical intervention, but many a time practically we may not wait even this much to do a surgical intervention. Now, what are the various surgical management? You can do a paracentesis and anterior chamber washout. You can do a limbal delivery of clot expression, and vitrectomy probe can be used to cut or aspirate the hyphema. Now, one of the point which we have to note here, when we use a vitrectomy probe, make sure that you don't injure the other structures inside the eye. Like when we try to pull out the hyphema, there are chances that we can make an iatrogenic iridodialysis. Of course, special issues like sickle cell disease, which may not be extremely common in our practice, this has to be taken care. The prognosis for visual recovery usually depends on the other structural damages. If there is a secondary hemorrhage, again the prognosis is little not so good, and corneal blood staining, and if the patient is already getting into glaucomatous optic nerve damage. The other common entity which we see is angle recession glaucoma, wherein there is a tear between the circular and the longitudinal ciliary muscles. Usually the initial trauma, it creates a proliferative or degenerative changes, and then there is a subsequent scarring of trabecular meshwork leading to ultimate dysfunction of the outflow pathway. Literature says that about 4 to 9% of more than 180-degree angle recession can cause glaucoma. Now, these are the various features which we can see in angle recession glaucoma. There can be an irregular AC depth, iris root or sphincter tears, peripheral anterior synechiae, Washer's ring, cataract, and other posterior signs of trauma. This is a typical gonioscopic finding, wherein there is a broadening or a grayish band which is seen in the gonioscopy, which is like a widened ciliary body band. Always try to compare with the other eye to understand whether it's a normal appearance or an angle recession. Of course, medical therapy, ALT has shown 23 to 27% success rate. Rarely we have to plan for a surgery like trabeculectomy with antimetabolites, or sometimes if it's intractable, shunt surgery may be indicated. Other common causes, ghost cell glaucoma, wherein there is an open angle glaucoma. Usually it is following vitreous hemorrhage, wherein we see these khaki colored cells due to the partial loss of hemoglobin. They go and occlude the trabecular meshwork. So usually this is a picture not from my clinic, it's taken because I have personally not really seen this candy stripe sign, but it's a very common explanation which is seen. Medical therapy, and many a time surgical surgery might be indicated like a vitrectomy or a vitreous lavage or an AZ lavage. Lens-associated glaucoma, it is similar like in any other lens-associated glaucoma. Since there is a talk by Dr. Manju, I am not going into the details. It can induce phacomorphic glaucoma, they can have lens particle glaucoma, they can induce phacolytic lens-induced uveitis also. When we talk about penetrating injuries, as soon as a penetrating injury happens, there is an immediate decrease in the intraocular pressure. When the closure happens, there can be a raised intraocular pressure. What are the mechanisms involved? It can be red blood cell related, it can be due to the lens, it can be due to angle closure, or it can be due to retained intraocular foreign body as well. How do we manage these cases? First and foremost, minimize the development of chronic aqueous outflow obstruction. So what do we do that? So this is a case of penetrating injury. So you make sure that the wound is tightly closed. There are no incarcerated uveal tissue. They've made it aphakic. If there is a lens injury, make sure that aspiration of lens is complete and the anterior chamber has to be reformed completely so that peripheral anterior synechiae formation is reduced. Steroids to avoid scarring. Once we make sure that there is no infection involved, steroids have to be given. Anti-glaucoma medications, and sometimes shunt surgery. So this is a patient wherein I have done a trap, but it's almost a flat scarred bleb and the pressures are going up. So we are planning for a shunt with a SFIL. Chemical and thermal burns, usually there can be a rise in IOP due to collagen shrinkage and prostaglandin release. As any other case, avoid cholinergic and PGAs. Thermal burns, why does it cause intraocular pressure raise? Large quantities of intravenous fluids to maintain the blood pressure can induce a massive periorbital swelling, and that result in increased IOP. So most of the injuries which we encounter in clinic is due to either sports or industrial injury, and it has been always reiterated that 90% of these injuries are preventable with protective eye care. So whenever we deal with patients, please ensure that at least they wear protective eye care in their future endeavors. Thank you.
Thank you, Dr. Meena. That was a very informative presentation. Over to Dr. Manju Anup for talking on lens-induced glaucoma.
Very good evening. I'll be talking on lens-induced glaucomas. So based on the mechanism, lens-induced glaucomas can be classified into open angle and angle closure glaucomas. In the open angle group, the important ones are phacolytic glaucoma, lens particle glaucoma, and phacoantigenic glaucoma. In the angle closure group, we have phacomorphic glaucoma and glaucomas associated with ectopia lentis. So coming to phacolytic glaucoma, as the lens ages, there will be stretching of the lens capsule and accumulation of high molecular weight lens proteins in the cortex. And these lens proteins will leak through the intact capsule, through the microscopic openings in the intact capsule of the mature cataract, and these lens proteins either directly obstruct the trabecular meshwork as in soluble lens protein theory, or get engulfed by macrophages and cause trabecular meshwork obstruction and cause glaucoma. This is a visual microscopic picture which is showing a liquefied cortex and wrinkled capsule with a Morganian cataract. So the clinical presentation, the patient will give a history of progressive diminution of vision since months or years prior to the presentation, and they present with acute painful eye, and they drop in whatever vision they have. So sometimes they will have headache and vomiting. If the intraocular pressure is very high, there will be associated photophobia. there will not be any history of trauma in these cases, and patient will present with low diminution of vision. On examination, there will be conjunctival congestion. Depending on the intraocular pressure, there can be epithelial edema. Anterior chamber will be deep in these cases, and you can see the lens matter in the AC, and it's known as pseudohypopyon. There will be a raised intraocular pressure. Again, you can see a mature cataract. Gonioscopy may not be possible, but the angles should be open. There won't be any KPs on the endothelium. So, what all differentials you have to keep in mind? One is acute angle closure glaucoma, where you have a shallow anterior chamber depth. In uveitic glaucoma, you will have other signs and features of uveitis like KPs and all. In neovascular glaucoma, you will be able to see the new vessels. If it is chronic, you may be able to see the ectropyon UVA and sometimes hyphema. And traumatic glaucoma, madam has already explained. So coming to the management, initial management is you have to control the inflammation and intraocular pressure, for which you have to give topical steroids, topical cycloplegics and anti-glaucoma medications. You might have to give systemic anti-glaucoma medications also. Cataract extraction is the definitive treatment. It may be plus or minus IOL. You may end up in putting a CTR also. Combined surgery should be planned if it is long standing. That is the onset of symptom to the surgery. If it is more than 3 weeks, you may need to plan a combined cataract with trabeculectomy. For cataracts extraction, SICS may be a safe option. Coming to lens particle glaucoma, here there will be a disruption of the lens capsule. It may occur after a cataract surgery or penetrating lens injury, and this will lead to release of the lens particle into the anterior chamber, and this lens material is toxic, and this exposed lens material will cause inflammation and they can lead to aqueous outflow obstruction. Patient will have a may present weeks or months or years after the precipitating event, will give the history of surgery or trauma. Patient will present with almost same as in phacolytic glaucoma, like acute pain, diminution of vision, redness. On examination, there will be conjunctival congestion, epithelial edema, anterior chamber, there will be cells flare, and you will be able to see the cortical lens matter in the anterior chamber. Intraocular pressure will be elevated. There can be peripheral anterior synechiae or posterior synechiae, angles usually open. Again, the initial management is the same, control of inflammation and intraocular pressure. Maybe you have to look carefully for the residual lens matter. Sometimes the lens matter can be present in the tunnel of the cataract surgery, or sometimes it may be in the angle, so careful gonio is very important. And if the lens particle or the material does not get resorbed, or if it is a large amount of the lens particle in the anterior chamber and the intraocular pressure is not getting controlled with the medical management, you may have to do a surgical removal of the residual lens matter. Coming to phaco-antigenic glaucoma, it is an Arthus type immune complex reaction which is mediated by IgG and the complement system. So there will be history of a trauma or surgery which lead to disruption of the lens capsule, and these lens proteins are exposed to circulation and they are recognized as foreign by the immune system. So this will initiate a granulomatous inflammatory reaction directed against own lens antigens, and this will lead to obstruction of the trabecular meshwork and increased intraocular pressure. Again, there will be a latent period of 1 to 14 days between the lens protein exposure and onset of inflammation. And the clinical findings, again, it includes circumcorneal congestion. There can be KPs on the endothelium, moderate cells and flare with hypopyon. Sometimes this hypopyon may be blood tinged, and this will give a clue that is a phacoanaphylactic glaucoma. You can see the residual lens material in the AC synechiae formation. Sometimes there will be low grade vitritis also. Intraocular pressure will be elevated and it will be open angles. The management is same, initial management is same, and if medical treatment is unsuccessful, here also you have to do a surgical removal of the residual lens material once the inflammation is under control. Next, in the angle closure group, you have phacomorphic glaucoma. So, mature cataract can lead to forward movement of the lens iris diaphragm. It can lead to an irido-lenticular contact or a direct irido-trabecular contact, and it can present as a chronic angle closure or sometimes present as an acute angle closure. This can be either appositional or synechial. So the clinical presentation, again patient will have a decreased vision. It can be reduced to up to hand movements or PL. In acute cases, there will be lid edema, circumcorneal congestion, corneal edema, shallow anterior chamber with cells flare, peripheral anterior synechia might be there. In the acute case, again there will be mid-dilated fixed pupil, and you will be able to see the intumescent mature cataract, raised IOP, and the angles will be closed. You have to do a gonioscopy for the fellow eye to rule out occludable angles. If it is a chronic angle closure, you may not get the signs and symptoms of the acute attack, but the pressure will be very high with closed angles. So the first picture is an acute attack, and the second one is a chronic angle closure, phacomorphic glaucoma. So the differentials you have to consider is primary angle closure disease and secondary angle closure, which may be due to choroidal lesion or effusion. Maybe you have to rule out a plateau iris, iris or ciliary body cyst, and ectopia lentis. Management, reduce the intraocular pressure and control of inflammation as the first line, and once you control the IOP and inflammation to some extent, LPI should be tried, and later you may end up in doing a cataract surgery. Parasympathomimetic agents should be used with caution since they can precipitate pupillary block. In the fellow eye, you have to do a prophylactic PI if it is occludable angle. If the IOP is not getting controlled with the medication and after LPA and it is very high, you might need a combined surgery. Shorter the duration between the onset of symptoms and surgery, the better prognosis of visual acuity. Next is glaucoma associated with ectopia lentis. There will be a history of trauma or associated with systemic disease which can lead to anterior subluxation or dislocation of the lens, which in turn lead to pupillary block and angle closure. So the first picture was a patient with history of trauma who presented with acute onset of symptoms, and on examination the part of the lens was in the AC and a pupillary block, mid-dilated fixed pupil. So we gave mannitol and tried to reduce the pressure to some extent and did a PI. So with one shot I could open up the, get an opening, and I just re-examined after an hour. The second picture is showing the lens position after an hour. Lens has gone back and it was behind the iris and it was like subluxated inferiorly. So by next day it went into the vitreous and then the retina surgeon took it out. So the next picture is, it's again a traumatic case, and there was anterior subluxation of the lens, but it was still in the pupillary plane. So the management, if there is anterior subluxation but there is no pupillary block and good vision, do a conservative management and monitor the intraocular pressure. If there is anterior subluxation and pupillary block with good vision, do an LPI alone. If there is complete dislocation into the anterior chamber or vitreous, removal of the lens is the definitive management. So to conclude, lens particle glaucoma and phaco-anaphylactic glaucoma need removal of the residual lens matter. In phacomorphic and phacolytic glaucoma or dislocated lens, you need a lens extraction. The surgery can be challenging because there can be a low endothelial cell count, shallow AC, small pupil, brittle capsule, rhexis extension, zonular weakness. Dislocated lens may need sometime limited anterior vitrectomy. Laser iridotomy will relieve the pupillary block prior to the surgery. Thank you.
Thank you, Manju. That was a very good presentation. invite Dr. Smita to speak on drug-induced glaucoma.
Good evening all. Drug-induced glaucoma can be classified into open-angle glaucoma, especially with steroids, and closed-angle glaucoma, which can be a pupillary block glaucoma or a non-pupillary block. This is a case of 30-year-old female presented to our OPD in June 2020 with complaints of blurred vision, both eyes, and headache for the past 1 month. She is a non-case of exfoliated dermatitis on steroid treatment, systemic steroids, tab prednisolone 8 mg once daily. And on examination, her best corrective visual acuity in the right eye was 618 and left eye it was 612. And there was posterior subcapsular cataract in both eyes, and the fundus was normal with 0.5 cup disc ratio. Her IOP was 28 millimeter mercury in the right eye and 23 millimeter mercury in the left eye. So she was given anti-glaucoma medications and the IOP was under control. She underwent left eye cataract surgery in December 2021. And in November 2022, since her steroid treatment was high, her vision in the right eye decreased to 624 and her IOP was 48 millimeter mercury in the right eye with glaucomatous optic disc changes in the right eye. Her anti-glaucoma medications were high, but she was not getting controlled, and so phacotrap was advised. But she had a fracture in the right leg, and so she was lost for follow-up, and she came back in April 2023 with PL negative vision and glaucomatous optic neuropathy. She underwent phacoemulsification and trap in May 2023. This was her fundus picture. With in the right eye there was glaucomatous optic atrophy. So steroid-induced glaucoma can be a response to exogenous or endogenous steroids. It is called steroid-induced hypertension when there is rise in IOP but there is no glaucomatous optic neuropathy, and steroid-induced glaucoma when there is raised IOP with glaucomatous changes. In general population, about 1/3 population are moderate responders with IOP rise of 6 to 15 millimeter mercury, and 5 to 6% are high responders with IOP rise more than 15 millimeter mercury. The risk factors include patients with POAG, first degree relatives of primary open-angle glaucoma patients, children below 10 years, and older adults, high myopia, connective tissue disorders, eyes with traumatic angle recession, diabetes mellitus, etc. Topical steroids causes rise in IOP in 2 to 6 weeks, and this elevated IOP correlates with the duration and frequency of administration and the potency of the steroid. And Dexa and prednisolone have higher rise of IOP, while loteprednol and fluoromethanol causes less rise in IOP. Intravitreal steroids like intravitreal triamcinolone causes rise in IOP in 1 to 4 weeks after injection, and the IOP rises about 5 to 15%. And the risk factors include younger age, high myopia, and multiple injections. Periocular route is more dangerous. It causes prolonged elevation of IOP because of the long duration of action. And systemic steroids, they are the least likely to induce glaucoma. It may take longer duration for the IOP to rise. Chronic use of systemic steroids leads to cataract and glaucoma. And steroids, when used systemically and topically, IOP elevation is additive. And the skin preparations like clobetasol, betamethasone, dexamethasone, these are highly potent, while triamcinolone is medium potent, and fluoromethanol and loteprednol are of less potency. The oral steroids, the average time taken for IOP rise is months to years, while with inhalation it takes about 3 months, and with dermatological preparations also it takes 3 months. But topical drops result in increased IOP in 2 to 6 weeks, and IVTA injection 4 to 8 weeks. Posterior subtenon injection causes IOP rise in 5 to 9 weeks. So for prevention, monitor every patient on ocular steroids regularly. First follow up after 2 weeks, and then every 2 weeks for the next 3 months. If in the first sign of steroid response, change to NSAID or low potent steroids like fluoromethanol or loteprednol. Choose an easily reversible method like oral and topical instead of subtenon and intravitreal. On chronic systemic steroid usage, 4 monthly checkup is needed. So treatment is discontinuation of steroids and control of IOP with anti-glaucoma medications. If not controlled, you can try laser trabeculoplasty and filtering surgery. Angle closure glaucoma can be pupillary block glaucoma in a pre-existing anatomically narrow angle like with anti-cholinergics, adrenergic agonists, antidepressants, etc. or with the forward displacement of the lens iris diaphragm as in cholinergic drugs and anticoagulants, or forward displacement of the iris lens diaphragm due to ciliocoroidal effusions like with sulfonamide drugs. Sulfonamide-induced angle closure glaucoma is seen in antibiotics like sulfamethoxazole, diuretics like hydrochlorothiazide, anti-epileptics like topiramate and acetazolamide. This is a case of 35-year-old female presented with complaints of pain, redness, blurring of vision, both eyes, and headache for the past 2 days. And she was on topiramate for topiramate for migraine for the past 10 days. And her nadir vision was 6/60 and -3 spherical and -1.5 cylinder in the right eye. She was improving to 6/9, and in the left eye -4 spherical and -0.5 cylinder. She was improving to 6/6, and her IOP was 60 millimeter both eyes. And there was circumcorneal congestion, microcystic edema, shallow AC with mid-dilated pupil and a normal disc. She was managed with IV mannitol, IV and topical steroids, systemic and topical anti-glaucoma medications, and atropine eye drops. She was discharged after 5 days on topical steroids and atropine, and her IOP was 6 millimeter in the right eye and 8 millimeter in the left eye. This was the slit lamp photo on the day of discharge. So topiramate-induced angle closure glaucoma, in topiramate can cause osmotic disturbance within the crystalline lens, leading to hydration of the lens and thickening with the anterior displacement of the lens iris diaphragm. It can cause ciliary body edema and supraciliary effusion, leading to forward retraction of the ciliary body and mechanical angle closure. It usually occurs in a few patients, and the doses well within the normal range and in a normal anterior chamber depth. So it is an idiosyncratic reaction. It is usually a bilateral presentation with blurred vision is the most common symptom, and usually presents within the first 2 weeks of use, and myopia up to 8.75 diopters is induced, and UBM usually shows supraciliary effusion. Management is discontinuation of the topiramate, anti-glaucoma medications to control IOP. Pilocarpine is contraindicated in these cases. It causes further lens iris for diaphragm movement anteriorly, and oral IV corticosteroids are given to reduce the uveal effusion. Laser iridotomy is not useful as angle closure is not precipitated by the pupillary block, and cycloplegics should be given in such cases. Cholinergic agents like pilocarpine, acetylcholine, and carbachol causes forward movement of the lens iris diaphragm, especially in cases with zonular weakness and exfoliation syndrome. Anticholinergics like atropine, hometropine, they causes mydriasis and cause pupillary block. Antidepressants like tricyclic and tetracyclic antidepressants can cause pupillary dilatation, and antihistamines also causes pupillary dilatation. Botulinum toxin can block the ciliary ganglion and cause pupillary dilatation when injected near the eye. So patient should be counseled to seek care if any of the typical symptoms of angle closure glaucoma occurs. And at-risk patient should be evaluated by gonioscopy and should undergo laser PI prior to receiving botulinum injections. And anticoagulants causes massive vitreous choroidal or subretinal hemorrhage and causes forward movement of the lens iris diaphragm. The risk factors include exudative ARMD and nanophthalmos. Thank you. Now I would like to invite Dr. Girija for a presentation on postoperative glaucoma.
Good evening, everyone. Postoperative glaucomas. So these are very complicated because they are actually refractory to the conventional treatment, and they are very aggressive in nature, and also because of the repeated surgical procedures, there will be conjunctival scarring, which affects the outcome of the filtering surgery. And also the outcome, final visual outcome is also not good because of the coexisting retinal and optic nerve pathologies. So the causes, any ocular surgery can cause secondary glaucoma. I'll be dealing only with the common ones. The post-PKP glaucomas, usually 9 to 50% incidence has been reported, and it's more in case of when the PKP is done for infections like herpes virus infection, trauma, or regrafting. And it is difficult to diagnose because the tonometry itself is difficult in an irregular cornea. Sometimes it may be highly astigmatic. In the pre-op diagnosis is difficult, and even the post-op. Because of tonometry difficulties, and also to see the fundus also, it's with the hazy media, always prevents the proper visualization. But it's always better if you can diagnose the pre-op glaucoma. And GAT still remains the gold standard here. It underestimates the IOP in ectatic diseases, but no substitute has been found out. And the Pascal DCT is independent of corneal astigmatism and CCT, and it can be used if available, but again it overestimates IOP at higher values and underestimates at low values. The postoperative glaucomas in PK, it can be either an early onset glaucoma or a late onset glaucoma. Early onset, as you know, the high viscosity viscoelastics which are used to protect the corneal endothelium, if they are not properly washed, then they can lead to an early onset glaucoma. Then PK itself can cause tissue deformation, and it can promote inflammation and disruption of the blood aqueous barrier, and there may be clumps of inflammatory cells and serum components which can clog the trabecular meshwork. And fibrin-rich exudates, if present in the anterior chamber, can result in synechiae formation, both pars and posterior synechiae, and thus resulting in a pupillary block. Suturing techniques and transplant size is also very important. Either a same size donor button, long tight sutures can compress the iridocorneal angle, and it can result in a secondary glaucoma. This patient was operated for bilateral macular dystrophy. Left eye was operated, the left eye cornea was very hazy, so we couldn't see the fundus, and the IOP also could not be measured preoperatively. She underwent an optical KP, and she was on postoperative steroids. But the IOP started rising postoperatively, and 3 months later the IOP was found to be, with 3 drugs it was 34, and with 3 drugs we could reduce it to 20, and then later we couldn't taper the steroids actually. Then after 15 months the sutures were removed and the IOP came down, and we could reduce the anti-glaucoma medications. So the tight sutures, once removed, reduce the glaucoma. So proper surgical technique is very important. Less tight sutures, deep sutures, short ones with equal length on either side, and slightly larger donor graft. These can prevent ankle compression. Now, corticosteroids are essential to prevent the endothelial rejection and also to maintain the graft survival. But they can, as Dr. Smitha has already mentioned, the steroid response is very high after a PK because they require long-term steroid treatment, even more than 1 year, and very OD dosage usually is given lifelong. So, corticosteroid response can result in secondary glaucoma. And the steroids, there are various mechanisms, and also there will be persistent inflammation, late onset, which can result in pars formation and glaucoma, which is difficult to manage medically. DMEC and DSEC are becoming more and more popular now, and there is an early onset glaucoma due to the air bubble that you inject for the attachment of the graft. If you inject a very large air bubble, that will produce, the aqueous cannot, it will fill the anterior chamber, and the aqueous cannot flow into the anterior chamber. So a prophylactic inferior PI is always recommended, and so that the aqueous can flow through that into the anterior chamber. But if it is filled 100%, then there won't be any space. So it's always slightly underfill the anterior chamber. Then only aqueous can flow, and there won't be, the glaucoma can resolve as the air bubble absorbs. And the incomplete removal of the viscoelastic, prolonged steroid usage, especially in DSEC, can lead to glaucoma. So the prevention management is always diagnose a pre-op glaucoma, and prevention can be by proper surgical techniques, a donor graft and also the suture techniques, and always do a prophylactic inferior PI. Topical steroids, they reduce the risk of PS and PAS formation and pupillary block, but they should be carefully monitored, tapered and substituted. Local topical AGM should be given, and PGAs are better avoided in the early postoperative period. SLT is also showing promising results. Surgically, if the IOP is not controlled medically, then you can go for trabeculectomy, which has longer periods of graft survival when compared to AGV, but mostly GDDs have to be done for better control of IOP, and the tubes have to be placed. If it is a pseudophakic eye, it's easier to place it in the sulcus, because in the anterior chamber it can lead to again endothelial cell decompensation. Post retina surgery glaucomas, all the retina surgeries any retina surgery in fact can cause a secondary glaucoma. It can be either a PPV. Usually in PPV there is gas expansion, there can be with or without. You can get open angle as well as angle closure glaucoma caused by the gas expansion, inflammation, ciliary oil, the silicon oil, and then there is the corticosteroid response and the blood mediated mechanisms. So combined procedures have a more chance of producing secondary glaucomas, especially if it is for PDR, and then pseudophakic and aphakic eyes have more incidence of glaucoma because lens has a protective role. Scleral buckling can cause an angle closure glaucoma, especially in previously narrow eyes. And the encircling band, which especially if it's placed anterior to the equator, and it can actually impair the venous range from the vortex veins and can lead to swelling of the ciliary body. Again, the non-pupillary block glaucoma can be caused. And open angle glaucoma also can occur in scleral buckling. Then silicon oil, as you know, silicon oil can emulsify and it can block the trabecular meshwork. And this is also more in case of, it can also cause a pupillary block in aphakic patients. And again here also early and late onset glaucomas are seen. Intravitreal gases like C3F8, SF6, etc. can expand. They will expand and they can increase the IOP initially by open angle mechanism. Later on, by pushing the lens iris diaphragm anteriorly, it can cause a pupillary block glaucoma. And when there is intravitreal gases, always measure the IOP with a GAT, because if you do a usually other methods of tonometry may not be correct because the gases are compressible. And patient should be always properly educated. The importance of maintaining a prone position and also to avoid the air travel. And the glaucomas post-VR surgery, they should be initially, mild glaucomas should be managed medically with the anti-glaucoma medications and control the inflammation with steroids. And if there is a pupillary block, you may have to do peripheral iridectomy and always do multiple PIs. Actually, the photos are showing a patient following a PPV who came with severe inflammation and secondary glaucoma. We did PI, but it blocked and he came back again, and twice or thrice we had to do, and we then later did a surgical iridectomy. Glaucoma in pseudophakia is usually due to pre-existing glaucoma or a steroid response. Otherwise, if it is a very complicated surgery, it can result in secondary glaucoma. So always to prevent it, you can complete removal of the OVDs, and also in complicated surgeries, the excessive inflammation, they have to be managed with steroids. Then placing improperly sized and malpositioned ACIOL or PCIOL in sulcus, especially single piece IOLs, if you are placing in sulcus, their haptics may be sharp and it can rub on the iris pigment epithelium. It can lead to pigment dispersion and can lead to secondary glaucomas. And vitreous filling the anterior chamber, always do a proper anterior vitrectomy. So the aim in pseudophakic glaucomas is to lower the IOP to the high 10s or low 20s, never lower the tension to single digits. Anti-glaucoma medications and steroids have to be given, and in case of pupillary block, you can do a PI. So aqueous misdirection is another very common condition that occurs after any ocular surgery, mainly seen if angle closure glaucoma is operated with trabeculectomy. So they have to be diagnosed. It has all the other causes of very shallow AC has to be excluded with B scan, and you have to proper diagnosis and immediate management with steroids, cycloplegics and hyperosmotics. And laser, always make sure that a PI is done. PI is patent, and otherwise you have to repeat it. And if not managed, then you can do a surgical management with iridectomy, hyaloid or sonolectomy. Thank you.
Thank you, madam, for that informative talk. Now, I would like to invite Dr. Lita George for a talk on uveitic glaucoma.
So good afternoon to all. So my topic is uveitic glaucoma. So uveitic glaucoma is quite different in the way that both the disease as well as the treatment, both can give rise to raised intraocular pressure. Raised intraocular pressure is common in ocular inflammation. Around 10% of patients with uveitis do develop raised intraocular pressure. Certain subset of uveitis, that is anterior uveitis, older age at presentation, and chronic inflammation do have a higher prevalence of glaucoma. So you can have a uveitic related ocular hypertension where during the active phase of inflammation, the intraocular pressure is high, but the disc is normal, the field is normal. But when the raised intraocular pressure persists for a longer duration, it can affect the optic nerve, leading to visual field defects. Then it becomes a uveitic glaucoma. So based on the structure of the angle, it can be an open angle type or it can be an angle closure. Based on the course, it can be acute or chronic. It can be hypertensive uveitis or it can be a post-inflammatory glaucoma. And based on the etiology, it can be autoimmune, infectious, systemic or idiopathic. So in open angle, the mechanisms can be, first one, it can be due to increased viscosity of the aqueous humor. That is, when there is a breakdown of the blood-aqueous barrier, there is transudation of the proteins, which makes the aqueous turbid and increases the viscosity, causing raised intraocular pressure. Then it can be due to obstruction of the trabecular meshwork by the inflammatory cells in the debris, trabeculitis or inflammation of the trabecular endothelial cells, that is the main culprit in viral uveitis. Then it can be due to liberation of active substances like prostaglandins, and when the inflammation persists for a longer duration, it can result in scarring and fibrosis of the outflow channels. In angle closure, it can be due to pupillary block, that is when there is extensive posterior synechia, there can be iris bombae formation which results in pupillary block, or it can be due to development of a cuticular membrane over the angle. Or when the inflammation persists for a longer duration, you can get peripheral anterior synechia or neovascularization. And rarely in conditions like weak age, it can be due to a forward displacement of the lens iris diaphragm causing angle closure. And keep in mind that multiple mechanisms may work simultaneously to cause raised intraocular pressure. Now coming to specific uveitic entities which are associated with glaucoma, first you have Fuchs' heterochromic iridocyclitis. It is a chronic, non-granulomatous, unilateral uveitis of insidious onset. Patient usually belongs to the age group of 20 to 45 usually. It's unilateral but can be bilateral in 13%. You don't get that typical presentation of uveitis in Fuchs. That is, the patient doesn't come with pain, redness or photophobia. Usually the patient comes with a blurring of vision because of a posterior subcapsular cataract or with complaints of floaters because of vitreous cells. You get a low-grade iridocyclitis without synechia formation. There can be diffuse stellate capes over the endothelium. Glaucoma is an open angle type of glaucoma, and is usually the chronic inflammation leads to fibrosis of the trabecular meshwork, which leads to raised intraocular pressure. You can get Amsler signs, that is, fine blood vessels can occur in the angle. These blood vessels bleed while you do an AC tap for taking aqueous sample for PCR or on gonioscopy. One important point to be kept in mind is that controlling the inflammation has little or no effect on intraocular pressure, and so avoid unnecessary use of steroids in Fuchs' iridocyclitis. Glaucoma is usually refractory to medical management, and usually you may require a surgical intervention. Then you have the Posner-Schlossman syndrome, where you get recurrent episodes of unilateral non-granulomatous uveitis in young patients. The patient usually comes with complaints of blurring of vision and colored halos. Intraocular pressure may be in the range of 40s to 50s. You get a few kps, 2 to 5 kps on the endothelium. The prognosis is usually good. The intraocular pressure can be controlled with a short course of oral acetazolamide together with topical anti-glaucoma medication, but if the condition goes unrecognized, it can lead to glaucomatous damage. Then viral uveitis is one of the common thing which we come across in our clinical practice. Around 28 to 45% develop a transient elevated IOP. Acute rise in intraocular pressure in presence of active inflammation. That is the hallmark of viral uveitis. Herpes simplex, herpes zoster, and cytomegalovirus have been implicated in the pathogenesis. In the acute phase, it is the trabeculitis which is the culprit causes raised intraocular pressure, that is inflammation of the endothelial cells. When the inflammation persists for a longer duration, you get a chronic synovial angle closure. An acute step PCR for viral DNA or the Fuchs profile can be done, but as of now, the infectious uveitis treatment algorithm network recommendation is you can empirically consider viral uveitis when you get a symptoms typical, that is unilateral uveitis with raised intraocular pressure with decreased corneal sensations and diffuse or sectoral iris atrophy. You can empirically consider it as a viral uveitis and treat and start on long-term antiviral therapy with systemic drugs like acyclovir or valganciclovir. Topical antiviral therapy is not indicated when you are dealing with a uveitis, but when you have an associated corneal involvement in the form of keratouveitis, you can give a topical antiviral therapy. Then in juvenile idiopathic arthritis, it is not very common in our scenario. You need to have a step-ladder treatment of inflammation with topical and local steroids and sometimes immunosuppressants and biologics. Glaucoma recognition and treatment is very important. Surgical intervention like goniotomy and trap may be needed. Other uveitic entities can be HLA-B27 associated anterior uveitis, sarcoidosis, weak-age, Behçet's, and toxoplasma. Then coming to steroid-induced IOP rise, already Dr. Smitha has dealt with the topic. Any form of steroid, whether intraocular, periocular, or topical, can give rise to raised intraocular pressure. It is least common with systemic steroids. Triamcinolone, prednisolone, and difluoprednisolone are common culprits. It's less likely with fluoromethalone and loteprednol. Typically, it starts 2 to 6 weeks after starting the topical therapy, but it can occur even earlier, especially if the patient has already been primed to a steroid response. So risk factors has already been discussed, family history of glaucoma, extremes of age group, etc. So when you come across a steroid-induced glaucoma, try to shift to a lower potency steroid if possible. Consider alternatives like immunosuppressants. When the depot steroid is the culprit, excision of the depot steroid may be needed. Vitrectomy may be needed for intravitreal steroids, and rarely when the glaucoma is intractable, you have to go in for a trabeculectomy. Now coming to the medical management, acute suppressants are the main drugs of choice. These include beta blockers, alpha agonists, and carbonic anhydrase inhibitors. Prostaglandin analogs, they are not used in active inflammation and in viral uveitis. They are not absolutely contraindicated in uveitic glaucoma. Once the inflammation is controlled and you are getting a post-inflammatory glaucoma, you can use prostaglandins, but not during the active phase of inflammation and also in viral uveitis. Hyperosmotics and systemic acetazolamide can be tried as a temporary measure. Then when there is pupillary block because of extensive posterior synechiae, you have to do a laser iridotomy. That is the definitive management. You have to do multiple PIs on the most convex area of the iris. Since there is active inflammation, the PIs can get closed. That is why we recommend to do a multiple PI. Post-laser covered with steroids and mydriatic cycloplegics. Surgical management, TRAB may be required. As compared to primary glaucoma, TRAB in uveitic glaucoma has got a high chance of failure. So pre and post cover with steroids may be needed. Drainage devices like AGV and RD can also be tried. So to conclude, first establish the cause. If the cause for raised intraocular pressure is turbid aqueous, then you have to give steroids to control the inflammation, give anti-glaucoma medication, and if uncontrolled, go in for surgery. If trabeculitis is the cause, then again give steroids and control inflammation, give anti-glaucoma medication. If uncontrolled, go in for surgery. If pupillary block is the culprit, go do a laser iridotomy, manage residual uveitis with AGM. If uncontrolled, go in for surgery. If steroid-induced glaucoma is suspected, discontinue the steroids, try immunosuppressives and anti-glaucoma medication. If uncontrolled, go in for surgery. If synovial angle closure secondary to uveitis is the culprit, then manage the uveitis, try AGM. If uncontrolled, again go in for surgery. Thank you.
Thank you, Lita, for that excellent presentation. If anybody has any doubts regarding the topics that were discussed.
I have one doubt. You're all saying about inferior iridotomy, laser iridotomy. Will it produce photophobia? Because yesterday I have come across patients complaining of photophobia. I think they can hear me. Photophobia after inferior laser iridotomy. Even 2 days before I had a patient. The patient laser iridotomy was done in our department. Patient complained of photophobia and came to me. Is it no?
But no, I have.
There are two, the pupil is there and through the
I don't.
iridotomy also.
I haven't seen such a complication till date. I'm hearing it for the first time because the position of the this thing is.
It's exposed. It's exposed.
Yeah, it is exposed. Nowadays with laser PI, actually we don't go that peripherally. All the PIs are done a little bit so that it will be visible later, so that we'll know that a PI has been done. But this complaint I have not met with till now.
So usually 100 micrometer of laser iridotomy. I've never seen causing a.
I had a patient last OP day.
Now the photophobia need not be only because of the laser.
It happened after this, and this iridotomy was done in our department.
No, iridotomy was done.
The patient didn't have any.
Because we see multiple iridotomies done in pediatric patients also.
Usually we used to do it upper
Allah,
part.
is it immediate, madam? How?
Anywhere you can do it.
Usually we used to do it upper part.
No, that concept is not. Because nowadays we can do it anywhere because the arc opening is very small. We can do it anywhere, and what I have mentioned was actually for the silicon oil and the air block. So because they'll shift upwards, you have to do it inferiorly so that the PI will not be blocked by the offending agent. But nowadays, even otherwise in primary angle closure, we can do it anywhere. The other one was a peripheral basal iridectomy, which had to be done in the 11 o'clock or the 1 o'clock position. That was a surgical PI recommendation. And for high FEMA, how long do you wait for this thing AC wash?
So usually I pump in oral steroids. So there's nothing like that's what it's more of a theoretical waiting period where they say 35 millimeters, 50 millimeters, 70s and all that. So usually we see whether it is decreasing or not. A week or 10 days, if it's a very aggressive IOP increase, which is just not increasing, decreasing with any of your treatment, then probably you should think of removing the blood clot. But again, you have to understand the secondary leakage chance. So we have to explain to the patient secondary leakage and then take it. But usually, if it is just not showing any sign of decrease in IOP, that's a time when we need to think of it. But oral steroids many a time helps well.
Manju, do you regularly do this combined procedure for this lens-induced glaucomas if they are long-lasting? Because I have not done a single trap for the lens-induced glaucomas.
I have done TRAB alone actually, chronic patient presented late, a month later, and I have tried even mannitol even 3-4 times. Then those patients, since the pressures were in 40s and 60s, I have done actually TRAB alone because the pressure is still 60. So
Because we give mannitol and we go on with the IOL surgery, usually the pressure comes down. That's what we see in our practice.
most of the time,
Because this has been recommended, long-standing, for that you have to do a PI.
cataract surgery alone should work.
Yeah, cataract surgery alone works. That's what I wanted to point out. Because anybody can do a cataract surgery, so don't hesitate. Don't think that TRAB is required and you don't have to refer to a thing. Take the necessary precautions and you can do a cataract surgery alone, which will control this thing. Cynical closure and all. Maybe.
In post-niche loss time, either systemic or
So that's what now actually in our hospital we started giving. I think the frequency reduces.
for first episode, you are
No,
doing.
not first step.
Recurrent
If
episodes.
it is recurrent and if the frequency is like more, then actually they do now AC tap also.
PCR you will do.
PCR
Elizabeth, madam, can you please give memento to Dr. Meena?